Good evening, good morning, good afternoon, everyone, and a very warm welcome to this ICH webinar dedicated to chronic myeloid leukemia in 2026. It's 6 p.m. in Paris, 6 p.m. in Torino, noon in New York, and it is my real pleasure to see colleagues and friends from around the world joining us with a shared goal: improving the lives of patients with CML. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France, and I'll be moderating this new ICH webinar. Over the past 2 decades, CML has become a remarkable success story in hematology and in cancer in general, transforming from once a fatal disease into a highly manageable, but also, I think, curable condition for many patients. Yet important questions remain about optimal sequencing, treatment-free remission, long-term safety, resistance, and how, in general, to individualize therapy in an era of precision medicine. So today's webinar brings, and we're very honored having him with us, the king of CML, namely Professor Beppe Saglio. And he will share with us the latest evidence, some practical insights, and future perspectives in CML therapy. Beyond data, this is also a space for dialogue, reflection, and collective learning, very much in the spirit of ICH and its commitment to education and hematology without borders. Thank you all for being here, for your engagement, and for your dedication to advancing CML care. Let's begin. Professor Saglio, the floor is yours.
Thank you very much, Mohamed. First of all, thank you very much for the invitation for this webinar. And it's a great honor for me to be part of the International Academy of Clinical Hematology family. And I think that this will be a focus for discussing about the problem of CML. CML is not, I would say, at the moment, something which is finished in terms of research, of clinical biological research, but is continuing because we have new ideas, a new perspective for the future. First of all, the title of this webinar is How I Treat CML in 2026 is a little bit misleading because the better title should be How I Would Like to Treat CML in 2026, because some of the options that I'm going to present are not still available all over the world, but not even in Europe or in Italy in particular, where I live. So I think that this is what probably I think is the ideal way to treat CML, and probably will become the way in which I will treat patients in the future if all the permission, all the activities will be available. So these are my disclosures. First of all, the treatment goals. Now we can clearly state that the CML survival is similar to that of a control population without leukemia. And so the life expectancy is really very similar to the normal life expectancy. And what we have to improve is certainly the quality of life, because the TKI therapy is definitely introducing also some aspects which sometimes are not for all patients, fortunately enough, but for a part of patients are not pleasant, or in some cases also clear adverse events. And then we have to try sooner or later to achieve a real cure of the disease, what we call a TFR or treatment-free remission. But after a certain number of years, if after discontinuation of the TKI treatment indeed is occurring, is present, we can say that the patient is really cured for the CML. Of course, the objective, these three objectives are much more pronounced, all the three, for patients who are younger. For elderly patients, indeed, the possibility of achieving a stable relative cure is probably a little bit less important. It's always important, but probably even less important, because sometimes it requires some efforts, additional efforts, and we can say that is not probably worthy the goal of TFR in some of the patients. Therefore, the main goals of the treatment remain survival and quality of life. What is important is absolutely fundamental, is just to perform an essential diagnostic workup for all patients at diagnosis. This must include hematological evaluation and the clinical evaluation, in particular the spleen and the liver size, the serological and biochemical evaluation, in particular concerning the HBV and the liver enzymes and lipase, cholesterol, glucose, of course, the risk of having a latent or overt diabetes should be considered. Electrocardiogram too. And what is also important is that to establish the correct diagnosis of CML, which requires a BCR-ABL fusion that we can find with qualitative RT-PCR analysis, looking also for the type of BCR-ABL fusion, which is essential for the follow-up of the patients using quantitative PCR later on. Quantitative PCR per se is not essential at diagnosis. It's much more important to establish the type of BCR-ABL junction. And of course, it's important also to perform through a bone marrow aspirates, because is the cytogenetic analysis to confirm the presence of the Philadelphia chromosome or of additional cytogenetic abnormalities, which have certainly an aspect that we will see later in the prognosis and the outcome of the patients. In cases which are pH negative and BCR-ABL positive, of course, FISH analysis should be done to confirm the junction between BCR and Abelson. Among the baseline prognostic factors, certainly I would say the LTS, UTOS long-term survival score, is extremely important. It has replaced the SOCAL score based on the same parameters, very simple clinical parameters like the number of the white blood cells, the platelets, the spleen size, and so on. LTS is giving to the age of the patients less weight. And this is distinguishing the patients in different categories, which are the low, intermediate, and high risk, as you may see, whereas the historic, we say historic SOCAL index that was used before, the number of the low risk patients was quite limited, 40% approximately. Using the LTS score, we are decreasing the number of the patients which are falling in the high intermediate risk group, increasing those who are in the low risk. And why? Because the number of the patients, the survival of the patients after 5 years, these are data from an observational studies of more than 1,500 patients run in Italy, as you may see, is definitely different. I would say only 3 patients out of 22 CML-related deaths which were counted in this group were occurring in the low-risk group, so no risk of progression, whereas most of the progression are occurring in the remaining third of patients falling in the intermediate high-risk group. So LTS is absolutely essential just to give us the risk of having a progression. Fortunately enough, these progressions are not frequent even in these groups, but however, they have an influence, of course, for the treatment and the patients. So the patients falling intermediate and high-risk group should be monitor it very careful and with a particular attention to see if there are signs or something which is related to the progression of the disease. Concerning the first-line therapy, as you may see in Italy, we are using both second-generation TKIs and imatinib, but second-generation TKI in 50% of the cases approximately. But the second-generation TKIs are mainly used in younger patients with respect to what we see in elderly patients, where we use in most cases, particularly over the age of 70, imatinib. And this is quite logical. We will think about this. But what is important is the median age of the patients who are treated with imatinib is overscoring that one of the patients treated with second-generation TKIs over approximately 15 years. So this is quite different. So these two categories of patients cannot be immediately compared. But it's important, however, that the reasons why we are using these two categories of drugs in a different way, because of course we know that the second generation TKI are particularly, I would say, available or for patients who are young and who have maybe also for patients who have, I would say, lacking of comorbidities, whereas imatinib is much more tolerated for patients who have side effects and for other reasons. So because we know that on long term, we have a great experience with imatinib, is definitely less toxic. Whereas the second generation TKIs induce a deeper and faster molecular response. But now we have a new player that we hope to have the possibility to use as first-line therapy also in most part of the world. Is already available as first-line therapy in the United States, in other countries like all the Middle East and some other places, in which you may see that this new player is called Asciminib. Asciminib is a different type of TK inhibitor, which is not binding the ATP binding pocket, where all the TKIs that we are using registered at the moment are binding, but are binding a medisteroid site, the medisteroid pocket, maintaining the molecule, the BCR-ABL molecule, in a closed conformation, and therefore this closed conformation is indeed inactive from the phosphorylation point activity, and therefore cannot phosphorylate the substrates, and this block the transmission of the BCR-ABL induced signal. Another aspect which is very important is that the pocket, medisteroid pocket, is much more specific for Abelson with respect to the ATP binding pocket, which is in part similar in all the different TKIs that we have in the human genome. We have approximately 100, 110 different genes coding for TKIs, which are all governing very important metabolic and pathways in the cells. And in this case, we expected that most of the inhibition is for the Abelson and BCR-ABL, of course, whereas with respect to what we have for these for the other TKIs, which are binding the TKI, the ATP binding pocket, and of course they can of course be responsible also of off-target target effects, because they can also inhibit other tyrosine kinases present in the human genome. The second point is the Asciminib, although may of course be susceptible of causing of emerging mutations in the medisteroid pocket, however, is insensitive to the presence of mutations which are present in the ATP binding pocket. And therefore, the activity can be used also to overcome some of the mutations. Not all, but these mutations include also the 359 mutation, which can arise in patients treated with the second generation TKIs. Why it's so important? Why we think that this Asciminib will be so important for as first-line therapy for at least groups of CML patients. First of all, because it's extremely well tolerated, and this is because it's lacking probably most of the off-target effects as we have seen before. Indeed, the rate of discontinuation, indeed, as you may see, is much lower with respect to what we see not only with imatinib, but also what we see with the second-generation TKIs, and the adverse events are definitely lower. These are the data which are emerging for the first study, which was the study that has led to the registration of the drug as first-line therapy. In terms of efficacy, then, you may see that indeed, after having achieved the primary endpoint, which was MMR after 1 year, indeed, the 2 years follow-up are showing that the higher number of patients are achieving not only a higher rate of MMR, but also a higher, deeper molecular responses, MR4, MR4.5. You may see that MR4, the gap between Asciminib and second-generation TKIs is particularly relevant. In terms of MR4, not so relevant as before, but this is only a follow-up after 2 years. So we may expect that more MR4 will become MR4.5 during the third and the following years of treatment. So these are data very important, which are supporting the idea that it is extremely potent TKI, which are able to induce a very fast and deep molecular response. And this, in spite of a very, very good tolerability, you may see that in adverse events leading to discontinuation are only occurring in 5% of the patients versus more than 2 times what we are seeing both with imatinib and with second-generation TKIs in the first study. And also the rate of patients who have to adjust the dosage or to interrupt or to adjust the dosage during the therapy is lower with respect to what we see in particular with second-generation TKIs. The idea that is the ideal, although this should be demonstrated in further study, but however, that the idea to achieve a very fast and deep molecular response leading probably to a higher rate of treatment discontinuation is coming also from the preliminary results which are coming out of this study, which is called Ask for Start, which is a study originally designed just to study the tolerability of the drug with respect to nilotinib, which in terms of efficacy is probably the best competitor that we have with Asciminib. So the primary endpoint was the number of the events leading to discontinuation of the therapy. There was an interim analysis already after that a total number of events leading to continuation was 50, and the cutoff of the data are showing that indeed the 2/3, this is from the statistical point of view highly relevant, of these events were occurring in the nilotinib arm and not in the Asciminib arm. So this is an important time point leading to the safety of the treatment, but also, and these are very preliminary results, but however very important in terms of efficacy. You may see that with respect to nilotinib only, in a large number of patients in this case, altogether are almost 600 patients, 300 and 300, you may see that indeed also only after 3 months of therapy, indeed, I would say almost 70% of the patients are achieving a value of BCR-ABL corresponding to the complete cytogenetic response, versus only 52% of the patients treated with nilotinib. And already after 3 months only, some patients are showing already MR4 or MR4.5. So these are data which are indeed convincing us that probably in terms of efficacy associated with a very good tolerability, Asciminib will be probably in the near future the best drug at our disposition. So I think that although, of course, one of the problems associated with Asciminib will be the cost, because the cost will be higher, being now both imatinib and second generation TKIs, and nilotinib and dasatinib also bosutinib generic. Indeed, we must consider Asciminib as first-line therapy, even for the cost in some cases. First of all, there are patients who do not care about the price of the drug, can afford it, and so they want to be treated in the best possible way. And so we must present this data and show them, if you want, these are the possibilities. And in women, however, who wish to become pregnant, in which they wanted to achieve a very deep molecular response in a very short period of time, and then maybe to restart the treatment or to change the treatment. But however, certainly they needed to become in a deep molecular response as soon as possible if they wanted to have babies and so on. But also in another category, in fragile and elderly patients who cannot tolerate imatinib, or in which imatinib, because of problem of fluid retention and so on, is not totally indicated. Maybe we can also have different strategies for these patients, lowering the dose and so on. But however, this is something that we must consider and study in the future. So after having established that the therapy is essential, however, to monitor the responses, this should be done, of course, during the first period of time, indeed using the hematological parameters, but RQ-PCR is becoming, as we have seen previously, recommended every at least 3 months until the achievement of major molecular response, 0.1% of BCR-ABL, which is considered the safe haven. Very few patients who achieve this goal are subsequently losing this response if they continue, of course, the therapy. And this is important. Thereafter, 3-4 months intervals between testing are justified if the patient remains in stable MMR or deeper response level. I think that at least twice a year it's important to see the patients to convince them of the importance of being adherent to the therapy and so on. Of course, more frequent molecular monitoring if we decided to discontinue the treatment, if we decided to lower the dosage after achieving a certain degree of response and so on. So there is a certain degree of flexibility which is left to all the doctors and also in part to the disposition of the patients. Now, we have, however, once the response is not optimal, we have the possibility to change therapy and to move from one TKI to another, to other TKIs. This, in our days, as we have seen also in one of the previous slides, for the patients who are treated with imatinib or the patients who are treated with dasatinib or nilotinib as first-line therapy, occurs in approximately 30% of the cases. Much lower, as we have seen apparently with Asciminib, but we are waiting for a longer follow-up. But what is important and what has been changed in the European Leukemia Net recommendation 2025, published with the first name of Jane Apperly, and that I would say that some days ago retired, and so I wanted to say hello to her and to thank her for all what has done for the CML therapy and the studies in all these years. But what I want to say, coming back to the table, is that indeed we must distinguish, I would say, the type of responses which have been denominated in our days favorable, so we don't have to change because the patient is probably assuming the drug in the regular way. What we can say is so the response is not dramatically good, an unfavorable response. But independently from the type of response that you're observing, what we have to do is just to change therapy in only 3 conditions. If there is a loss of a previous response, because this means that there is emerging a new clone. If there is the appearance of resistant mutations, because if they are not if generally this is associated with the loss of response, of course, and if there are the appearance of additional cytogenetic abnormalities, which means that the patient is entering a phase almost of, if not of progression, at least of, we can define, of pre-progression of the disease. So in these cases, we definitely need to change the therapy. In all the other cases, we must balance, evaluate which are the advantages and disadvantages of changing the therapy. And this is due to the consideration that have been done in the last years, mainly due to the studies of the German group and also of the MD Anderson group, just showing that in a very long follow-up, also the patients who are not responding according to the, let's say, strict European Leukemia Net milestones in the perfect way, indeed they have a quite good survival, as you may see. At 3 months, just to be above 10%, or at 6 months is not so relevant in terms of the overall survival. The difference is less than 10%. It becomes relevant only after 1 year or 2 years and so on. So if after a long period of time it remains a large burden of the disease, patients are not achieving CCYR, later on we say this will cause a damage for the patients. So we have to consider this. And this observation, which is telling us probably the patients, not all the patients benefit to change therapy, but if the therapy is very well tolerated, is also another observation done by the MD Anderson group in this case, and showing that indeed patients, elderly patients above the age of 60 years, who are not achieving MMR after 2 years, they are of course dying. The overall survival is, as you may see, is going down, but they are elderly patients, but are not dying because of CML-related causes. So the risk of dying because of CML, even if you remain with a quite high, with a certain degree of disease, this is very MMR, so it's quite a good response. Once that you achieve or do not achieve MMR, sorry, if you are not achieving MMR, but you are, for example, in CCYR, this does not necessarily mean that you have to change the therapy. This must be judge evaluated for every time. And this is an observation that we have done here in Italy in our observational studies. And you may see that indeed not being in a complete cytogenetic response, the corresponding value of BCR-ABL to complete cytogenetic response after 12 months therapy is definitely associated with the lower overall survival probability, but this is not due to that related to the CML. And the median age of the patients who are indeed not achieving this goal after 1 year of therapy indeed is, I would say, goal in terms of the CCYR. Indeed, I would say the age, median age is at least 10 years higher with respect to what they achieved the goal. So there are other factors which are influencing the survival of the patients other than the progression of the disease. And this is extremely important because we need to know at the moment that indeed the reason for this the effect, we can say, is because there are late responders which are going down little by little, and there are beneficial tyrosine kinase effect even if the milestones are not reached. And this is because with the TKI, indeed, we are switching off the TKI activity of the TK activity, sorry, of the BCR-ABL, which is a highly oncogenic element, and therefore in this way the clone remains, but it's, I would say, almost neutralized, unless that there is extremely high, and in which in these cases, of course, probably there is something not working, and the risk of having mutations and so on leading to a progression of the disease may still be present. And so this also is telling us that it's essential to continue the TKI therapy in any case, even in cases who are not achieving the milestones. Never switch back to hydroxyurea, for example, and so on, because just simply to maintain an hematological remission and so on, because this is a mistake. The patient should continue the TKI therapy because this is neutralizing the remaining pH positive cells and BCR-ABL positive cells. So, as a second line therapy, however, there are differences if you are starting with imatinib or with second generation TKI. If you're starting with imatinib, generally we move to nilotinib, dasatinib, bosutinib. Ponatinib is allowed only in Italy if we have the 359 mutation, but generally we are moving to second generation TKI. If we are starting with second generation TKIs already, generally the preferred is just to move to ponatinib. Asciminib is, as we will see, still in study. And we can use the other second generation TKIs only if there is a problem of intolerance rather than a problem of true resistance, or if there are specific mutations which are sensitive to one but not to the other second generation TKIs that we have at our disposition. We know that moving from imatinib to second generation TKIs is giving us approximately, with all the drugs, the same results. CCYR by 2 years in 50% of the cases, MMR in a percentage which is ranging between 37 to 28%. And we can say that 64%, so 2/3 of the patients who are in CCYR also obtained and maintained later on MMR for a certain period of time. Patients who are resistant this is a flow of the patients who are treated in Italy as a second-line therapy. As you may see that indeed patients who are already started with second-generation TKI are mainly moving to ponatinib at this point. There are some few cases who moved to asciminib, but this is because these are data perspective. So asciminib has been introduced very recently in the therapy of the patients. Then what we have is that most of the patients treated with imatinib indeed are moving to dasatinib, denotinib, or bosutinib, and this is rather important. Then as third-line therapy, at the moment, the prevalent therapy is represented by ponatinib. And we can select, of course, the type of TKI based on the presence of possible presence of mutations which are conferring resistance, mutations of the ATP binding pocket. And of course, the 359 mutation was mainly sensitive to ponatinib, only sensitive to ponatinib, but all the others also sensitive to ponatinib, as we may see. But we must consider that in the future, most of these mutations are also responding to asciminib, that were including also the 359 mutation. However, we cannot use a second-line therapy. Maybe in the future, and I'm telling this because there are very interesting data which have been presented just in recently at ASH 3 months ago, derived from this United States based study, which is called Ask for to Escalate study design, and these data were presented by Cortez, as you may see. And at the moment, which is a rather complex study, let me say, but at the moment we must focus on the second line cohort, which the patients indeed were resistant to not only to imatinib but also to second generation TKIs. Indeed, were moved directly to asciminib 80 mg per day, and in case of not achieving a good response, they could also dose escalate, but of asciminib. At the moment, what we can say that this group of patients were not only therefore resistant to imatinib, but 50% approximately, even more, were resistant to second generation TKI. The duration of the previous TKI therapy in most cases was most of 1 year. And the BCR-ABL level at baseline were in 60% or more of the cases above the 1%, in some cases 30% also above 10%. So there were a higher percentage of resistant patients. There are patients who were mainly intolerant to the therapy, who were already in 1%, below 1% of BCR-ABL, but were enrolled because they were intolerant. So what is important again is that most of the patients were indeed patients who were resistant, particularly to and at least 50%. And this is rather important also to second generation TKI. Again, in these 100 patients approximately that were examined, indeed you may see that 83% are still ongoing treatment and discontinued for treatment, but discontinued for treatment because of adverse events were only 8% of all the patients. So this is a much lower percentage with observed with respect to what we have observed with all the other TKIs previously used. And so this is extremely important. And what is also even more important, and that, of course, the deep molecular responses that you may see can be achieved in a third, almost a third of the patients in terms of MMR, and also in some patients in MR 4.5. But we must consider that these are data that maximum achieve 1 year of treatment. And week 48, so 1 year after the start of the switching of the and this is telling us that probably this will be a very good condition, particularly for patients who are in a very, I would say, they wanted to achieve a deeper molecular response and not having achieved this goal early with the previous treatment. And even patients with mutation, classical mutations, can respond. And this is, however, should be analyzed in a larger number of patients and more in details to decide. So that's why I think that probably also Asciminib will become an option, a second-line therapy in the future. Overview of adverse events regarding of treatment relationship. All grades of severe adverse events were much lower with respect to much low, 13%, and leading to discontinuation also, as we have seen, 8%. So there is not a comparative analysis, but from the historical data, we know that these are very good results, very good data, much lower than before. So having said this, of course, one of the problems that we may face in our clinical practice is that there are patients, young patients maybe, who want to achieve a deep molecular response, but they are not achieving it. So if they not achieve a response suitable for allowing to discontinue the treatment, what can we do? Just to switch. This has been done in the past from imatinib, switching from imatinib to nilotinib, for example, or to dasatinib, but the results were not particularly interesting. Now there is the possibility to perform the same study using probably Asciminib, and this is a part of this Ask for More study in which indeed patients were in the value of BCR-ABL corresponding to CCYR, but not in MR4, were switched to monotherapy of Asciminib 80 milligram. This is only one part, one arm of the study, which is more complex, but we will not talk about this. And you may see that after, indeed, 1 year from the start of the switching, approximately half of the patients are achieving MR4, sorry, this is a mistake in the slide, this is MR4, and MR4.5 in approximately 30% after 1 year. So I think that altogether these are data that are suggesting that even a second-line therapy, not just in need of a, I would say, of resistance and so on, but just simply to achieve a deeper molecular response, if we have started even with, I would say, first or second generation TKIs, we can switch, obtaining probably good results. But this should be definitely evaluated in a larger study with a higher number of patients with the purpose to perform this. In part, this will be done already in the Ask for Stars study, but we need at least other 2-3 years of study to definitely assess this point. Third line therapy. Third line therapy, I would say the Italian experience, 15% of the patients need a third line therapy, mainly because intolerance, hematological toxicity, and so on. Third line therapy at our disposition is to simply change second generation TKIs, but this is generally tried only in cases with an intolerance, or to move to bosutinib, ponatinib, or to asciminib. I would say that the optic, most of the patients as we have seen previously are if moving to ponatinib. And ponatinib, however, is a drug and the TKI, which is a problem of cardiovascular toxicity, as everybody knows. But we have been able to modify or to limit the cardiovascular toxicity of ponatinib using a different therapeutic scheme. Certainly, these are derived from the study, the OPTIC study, in which patients were randomized 1:1:1 to restart with different dosages of ponatinib, 45 milligram, which was the original dose, ponat 30 milligram, or definitely to ponatinib 50 milligram only. And indeed, as you may see, that after achieving, however, a value corresponding to a complete cytogenetic response, 1% or less of BCR-ABL, the dosage of the drug was switched to 15 milligram to maintenance. And this study has shown that the best combination, indeed, in which is limiting the toxicity and is just to start with a full dose and then to move back to a lower dose as maintenance therapy. And this is what it appears as final results of the OPTIC study, which has already been published some year ago. Therefore, the current approach to ponatinib use is the patients with the 359 mutation. We generally start with the 45 milligram because this group of patients is particularly sensitive to the action of ponatinib. And then we move to 15 milligram once the BCR-ABL is only less than 1%. For all the other patients without the 359 mutation, indeed, we start only with 30 milligram because the difference between the results with 45 or 30 milligram is not so relevant. And then we move back, of course, to 15 milligram. Now, which is at the moment the collocation of Asciminib in this landscape. Certainly, we must remember that Asciminib was initially registered as third-line therapy and is already available as a third-line therapy in most of the countries of the world, I think. As you may see that this was the results of this Assemble study, in which Asciminib was indeed challenged against bosutinib, the dosage of 500 milligram once a day. Asciminib 40 milligram twice a day. Now it's become 80 milligram once a day, just to remember this. In patients without the 359 mutations, already resistance to at least 2 different TKIs, so treatment failure or cannot be treated. And the primary endpoint was MMR at 24 weeks, was reached, median follow-up, however. But what is much more important, even not only MMR raised after 24 weeks, primary endpoint, but FE48 and after 2 years from the start of treatment was greatly in favor of Asciminib with respect to bosutinib, more than double what you can see from these results. So the efficacy was definitely superior. But what is even more interesting is that indeed most of the patients, 50% of the patients, still are ongoing in treatment with Asciminib, which means two things: that the drug is very well tolerated, first of all, because you don't need to change it because of toxicity and so on. And the third aspect is that it is efficacious. Otherwise, you are trying to change the therapy. And at this point, I would say you have to try investigational drugs like probably you can move the patients to olverembatinib or other drugs at the moment, or you can, if for a young patients, also start to think to stem cell transplant, which is still a way available in our days, is becoming even a little bit increasing again. So, Asciminib is also active against the 359 mutation, but in a higher dose. So 200 milligram twice a day, which is 5 times the amount, is really effective. It's inducing, I would say, a good rate of response, even in patients who have been previously treated with ponatinib and probably were not only resistant, but also mainly probably intolerant, not only resistant to ponatinib. So this is a response which is our data, which are, again, of course, important. Although, of course, at the moment, I think that for the 359 mutation, the results of, personally, this is my opinion, results with ponatinib are difficult to be overcome. And probably what we can in the future try to test is just to achieve a good molecular response with ponatinib, and maybe in a second time to move to Asciminib to maintain the response later on with a lower degree of toxicity and so on. But also these are something that need the support of clinical data that for the moment are not available. So what can expect in the near future? Definitely there are a number of new drugs. So the research on CML therapy is not at the end, we can say, as someone probably is erroneously thinking. And probably we need also new combination therapies with between maybe different types of TKI linking and binding the ATP classical pocket or the merisylate site. We definitely we need new therapies for advanced phases because although the number of progression in this moment is quite limited, we have registered so far only 44, a total number of 44 progressions in more than 1,500 patients in the Italian CML registry, and of these some of these progression were in the blast phases were only 22 of all the cases, but these cases are still dying because most of the cases are still dying because of the progression of the disease. So we need to know. And definitely the next goal, we need to understand better this very strange and for the moment mysterious phenomenon which is represented by TFR, and just to achieve what is our final and definitive goal, the cure of the CML. Thank you very much. I want to thank, I want to remember to you that this association, which is International Chronic Myeloid Foundation, and this is, I would say, whose scope is to improve the outcome for patients with CML globally. And if you are going to the site of the foundation, you may see that there is a very nice initiative, which is just Climb for Cure, in which a researcher, the important researcher that are going to try to climb some of the volcanoes in Ecuador, and with the scope of, I would say, as witness of the effort that we must do for the CML therapy. Thank you very much.
Thank you very much, Professor Saglio, for really an impressive overview. I think you nailed it very nicely, and it was a true delight to listen to this webinar. So we have a few minutes to take a few questions. I'll focus on the practical questions because the audience is highly interested on the practicalities. In a T315I mutant patient, and if you have ponatinib and asciminib both available, which one do you prefer?
I would say in terms of efficacy, definitely, I think that the fact that we need a very high dose of Asciminib, I prefer ponatinib. But we know that ponatinib is associated with high risk of cardiovascular events, particularly on the long, not only on the long term, sometimes also in a rather short term, but we have been able in our days to manage a little bit of this toxicity, but we needed to be careful, of course, about these aspects. So, as I in part suggested, probably once that we achieve a good molecular response in a young patients, for example, but however, it's difficult to think that it's possible to discontinue the therapy in a rather short period of time, and we wanted to limit the risk, the cardiovascular risks which are associated. Maybe we can try in the future to switch to Asciminib, which is definitely, apparently, we need also in this case a quite long follow-up, just to reduce the score. This is can be a patients for a limited number of, I would say, patients, because you have seen that patients who are not responding to their line therapy approximately can be 2 to 3% of all the CML patients. The other options for the patients, and maybe I can ask you also your opinion about this, patients who is in CCYR, for example, after with the 359 mutation and with ponatinib therapy. 25 years old, do you move into transplant or not in our days?
I personally would say not yet.
Not yet.
Yeah.
Yes, but how long should we wait? I would say in 10 years' time, it's a problem. I would say that in these cases, I would say we have done a great improvement in terms of stem cell transplantation. Stem cell transplantation in a case like this is, of course, probably we can expect that is achieving later on, I would say, a TFR, is inducing a TFR, I would say. Definitely, it was the only way to definitely cure CML, as established already some years ago. So I think that indeed this is a difficult question that should be discussed with the patients, with experts and so on, but this is something that we have to answer in the next few years.
Thank you, Beppe. In the same vein, do we have a head-to-head comparison between ponatinib and asciminib?
No, no, for the moment we don't have it. We may have probably in the future only, I would say, observational study to go on, but for the moment we do not have a direct comparison in a clinical study making a direct comparison. However, I would say probably, I don't know, we can expect the same dosage, definitely higher activity of ponatinib, but also higher toxicity. Definitely, Asciminib will be better tolerated than ponatinib.
A quick question here from Dr. Bedrettin Oran from Turkey regarding or when using asciminib, what kind of drug interactions we need to be aware of?
But for the moment, very few have been described so far. I think that we do not have really to consider, I would say, generally TKI drug interaction is not so dramatically. So we can use for all patients without considering particularly limitation for this. Of course, once that we are using Asciminib, we must monitor quite carefully the patients. This is clearly, and to observe if there is something for which can indeed interact with them. Otherwise, I do not think that there are problems of interaction.
Excellent. Thank you very much. You have the compliments for the presentation of Dr. Serena Mirante, and she's saying hello and asking actually, uh, do you confirm that imatinib should remain the first-line therapy? And we have another question, so I'm adding it. Is there any added value for bosutinib over imatinib?
I would say for concerning the imatinib is a pillar. I do not know how to define it. I would say is the prototype of all TKIs is still extremely useful. It's a generic drug, is very, very good. I think that, however, for a younger population as we have in the world, we need something which is stronger than imatinib. So probably we must probably use, now that are becoming generic, also second generation TKIs. I personally prefer nilotinib with respect to dasatinib because I observed some cases of pleural effusion with dasatinib, even when you use 50 milligrams. This is but I would say even the dasatinib 50 milligram is a good option. I think that for as first-line therapy. For elderly patients, of course, imatinib still remain, I would say, probably the best treatment that we can have. And bosutinib for elderly patients is not so good because we know that elderly patients are suffering frequently of diarrhea, of gastrointestinal problems, and so on. This may lead to less tolerance for the patient. Certainly, what we have to improve is just the management of the dosage of the drug. We are probably using dosages of the drug which has been established, I would say, previously and by regulations and so on, which are probably for second generation TKIs in particular too high. Indeed, we are using dasatinib as first line therapy only 50 milligrams, and this is decreasing or not totally eliminating the risk of pleural effusion. We are using bosutinib, even we can start with the 200 milligram, then to increase it if there is no response to 300 milligram and to 400 milligram, which is the later on. But the 500 milligram that is still registered as third line therapy, we know that is probably too much and not so well tolerated by patients.
Another important question. In a young CML patient receiving nilotinib second-line therapy, the last PCR showing 0.1% after 1 year of treatment, and it remains persistent at the same level. Would you change drugs or no?
Young, what does it mean in this case? We do not know. Yes, I would change it. I would change it to Asciminib in this case, because I think that in this case we have in a year the probability of achieving MR4 in approximately 50% of the cases without so many side effects or risk of intolerance and so on. To move from imatinib to nilotinib generally is associated with 50%, 15% of discontinuation because of intolerance and so on. To move from Asciminib to from nilotinib to Asciminib is associated with a much lower risk of intolerance of side effects and so on, and probably also to a higher efficacy.
We have a question from Dr. Doreen Mohammed from Kurdistan. What's your preferred TK inhibitor as maintenance after allotransplant for a blast crisis CML?
Oh, okay. If you have moved the patients after allotransplant, it means that there has been a quite good response to the TKI. So to the TKI that you have used in blast crisis. So I think that the most important aspect is to continue with the same TKI because the positive original clone was sensitive to this original TKI, to the previous TKI. Maybe decreasing the dosage because after allotransplant, patients are not indeed tolerating the full dosage of TKI. For example, ponatinib 50 milligram is enough. For example, even every other day, sometimes you have used also this scamotage, and also lower dosages of all the TKIs that have been previously used. But generally, they have been patients treated with ponatinib previously or with dasatinib. So we can use dosages of this time.
One other important practical question. In a CML patient and pregnancy, do you see a remaining role for interferon alpha?
Interferon alpha is still suggested for patients who are losing the response. First of all, we can expect that patients who are I would say there are the difference. If there is a lady who wants to become pregnant, okay, in this case, we need to just to put her, if possible, to a best deep molecular response that we can. For the second one, we have a diagnosis of a CML in a pregnant woman. In this case, I think that the latter case we should consider which are the number of the white blood cells to achieve at least a complete hematologic remission. For the rest of depends on the months and so on. But we can use in this case also hydroxyurea, for example, more than interferon alpha, because we wanted to maintain a lower white blood cell count. In some cases, we need also leukapheresis, as we know, and so on in specific cases. If we have a patient in which indeed he wants to become pregnant or become accidentally pregnant, but having previously a diagnosis of CML, after being sure that she is pregnant, we must be absolutely discontinue any TKI therapy, monitor her. If there is a increase of the BCR Abelson, but losing MMR or even 1% of BCR Abelson, we can start interferon alpha or in order to try to limit and to see what is going on. We can restart eventually the TKI therapy, even in some cases during the third trimester when most of the organs have been already formed and so on. So there are not risk of teratogenic effect.
Thank you very much, Pepe, and apologies for all the colleagues. We have an incredible number of questions, but for the sake of time, we
If
can't.
they want to send me, I think that I have here my email address. They can write their questions.
Absolutely, absolutely. This was really outstanding. Thank you all for joining this ICH webinar dedicated to CML therapy in 2026. I think today's discussion reminded us how far the CML field has come from a once fatal disease to a model of precision medicine, and yet how much meaningful work still lies ahead with deeper molecular monitoring, smarter sequencing of TKI inhibitors, treatment-free remission strategies, and truly patient-centered care. We're not only extending survival, but improving the quality and ambition of our patient life. On behalf of the ICH, thank you to our outstanding faculty, top expert, Professor Saglio, but also to all participants from around the world. Your engagement is what transforms a webinar into a community. So
thank you very much, Mohammed. But I want to thank you just for the efforts that you are doing to spread the excellence in medicine, in hematology in particular, with this International Academy for Clinical Hematology, which is doing really a great, great job. Thank you very much.
thank you, Beppe. Coming from you, it means a lot to me. So we look forward to continuing this journey together, advancing science, sharing knowledge, and ultimately bringing more hope to our patient. Thank you all, and see you at the next ICH event.
Thank you.